Hey, it's Steve Kreinlich here to talk to you about carpal tunnel syndrome. What do nerves do? Nerves are conduits. All they do is carry information both to and from the brain. There are two types of peripheral nerves. One is the sensory nerve. This is going to carry information from the outside world to the brain. This is going to be touch and temperature and feeling. There's also motor, which is going to carry our impulses to our muscles. This is going to carry information away from the brain. Most commonly, nerves are mixed. They'll have both sensory and motor components. Nerves conduct information via an electrical impulse, not unlike a wire. Nerves are insulated, just like wires are insulated. This allows them to conduct better and more stably. The Schwann cells are cells that do this. The most common symptom of carpal tunnel syndrome is nighttime numbness and tingling. As carpal tunnel progresses, daytime numbness and tingling comes, and then sometimes weakness will present. It's possible to have proximal radiation of this numbness. It can go up the anterior arm, and 10% of the time it could be in the shoulder. With chronic cases, patients can show up with atrophy of the thenar muscles. This is nerve damage and muscle damage from prolonged constriction of the median nerve of the wrist. The anatomy of the carpal tunnel is made up of the transverse carpal ligament. This is the ceiling of the carpal tunnel, and it is closest to the skin. The carpal bones are the floor, and they're underneath. It's important to remember that this is a closed space, so that anything that did not used to be in the tunnel, but now is, can constrict the size of the tunnel, and thereby constrict the blood supply to the nerve. That could be synovitis, thickening of the tendons or the transverse carpal ligament, or arthritis. Wrist flexion and carpal tunnel. We know that the normal pressure in the carpal tunnel is between 2 and 10 millimeters of mercury. We know that there's a 10-fold increase in carpal tunnel pressure with wrist extension. There's a 20-fold increase in carpal tunnel pressure with flexion. So pathologic conditions like we talked about earlier around the carpal tunnel will increase the likelihood of compression, especially with wrist flexion. Hence the reason for nighttime symptoms. If the patient sleeps with their wrist bent, they'll have symptoms that wake them up. And this is why we encourage people to sleep with braces at nighttime so that they will not flex their wrists. So what's the incidence of carpal tunnel syndrome? It's incredibly common. It's 90% of all peripheral neuropathies. It's 4 to 5% of the general population at any time. Average age is between 40 and 60. Is a higher incidence in women, and it's due to chronic ischemia of the median nerve at the wrist. This is a study out of New Zealand looking at 3,000 carpal tunnel releases done over a 10-year period. 2 to 1 of their patients were female when compared to male. The average age was 56. Symptoms were worse by age by decade. Those that were 70s had worse symptoms than those that were in their 50s. Carpal tunnel diagnosis is made easily with a good history. In fact, you can pretty much make the diagnosis by talking to the patient. Nocturnal symptoms are more diagnostic than a physical examination. Physical examination should be confirmatory. Electrodiagnostic studies are often not needed. That means an EMG or a nerve conduction study is usually not needed to make the diagnosis of carpal tunnel. Ultrasound is very helpful, and in fact most recently has been shown to be more specific and sensitive on picking up carpal tunnel than electrodiagnostic tests. Recommendations for treatment of carpal tunnel are based upon symptoms and physical findings. Mild carpal tunnel syndrome has no motor involvement by definition. Recommendations for mild carpal tunnel syndrome are for nighttime splinting. Sometimes steroid injections are used. This is generally successful. Moderate and severe carpal tunnel syndrome have increasing problems with motor involvement and nerve degeneration and nerve death. These are treated most effectively with surgical intervention. Surgery is performed by transecting or cutting the transverse carpal ligament. Outcomes are improved when surgery is done in patients with moderate versus severe disease. Carpal tunnel surgery is done as an outpatient. We use local anesthesia, sometimes a little sedation if the patient is nervous. This can even be done as an in-office procedure in some patients. We use a small anterior incision and go down and release the transverse carpal ligament under direct vision. Those with worse or more severe carpal tunnel syndrome can take longer to heal. And it's important to remember if there is severe damage to the nerve, surgical treatment is not as effective as if it is done earlier. Here is a carpal tunnel release performed in the office. Local anesthetic is infiltrated to make the wrist and the hand numb. A tourniquet is used, and a small incision is made directly over the transverse carpal ligament. Next, we'll expose the transverse carpal ligament, and we will release it or cut it under direct vision. This will allow the nerve to recover as the constriction will be gone. This will be checked with a pair of scissors. Next, the wounds will be irrigated and closed with sutures. Light activities are encouraged after surgery. Heavy activities are discouraged until full healing of the transverse carpal ligament. Here is the size of the incision. Thanks for your attention.